All right, chapter 21. This is going to be a content outline for you. Make sure that you have this read and ready to go for next week. So the first part here, we just start out with bones and joints. We're going to move into osteoporosis, which is going to be the first one that we're going to outline. So you can just read through this stuff. There's nothing extra for me to add as far as content goes with this first one. But osteoporosis, this starts out on page 277. Your book says, is a normal process of growth. The bones increase in structural density. In the normal process of growth, the bones increase in structural density and strength through the accumulation of calcium and other minerals. So we know as people grow that the bones will be strengthened, and calcium and minerals are the things that help to build up the bones. At the same time, the bones are weakened as calcium and minerals return to the bloodstream. Peak bone mass is reached at about 30 years of age. And then so it goes into talking about osteoporosis, meaning a porous bone. Primary osteoporosis is so common in women that it is sometimes thought to be a part of the normal aging process. However, secondary osteoporosis is caused by another disease, and then it goes on to list some of the things that can cause secondary osteoporosis. In osteopenia, bone bone something density, BMD, bone mineral density, has been lost, but not to the extent of osteoporosis. So osteopenia would be something that could be a risk factor for osteoporosis itself. African American women have the highest bone mineral density, but they're still at risk. However, they are not high risk because they do have that highest bone mineral density out of all of the different cultures and ethnicities. It's going to move in to talk about a DEXA scan here in a minute. Yep. So DEXA scans can be done for people every 2 years if Medicare will pay for those that are at the highest risk. These DEXA scans will actually help to determine if the patient is developing osteoporosis, but not all insurances will cover that. It says the U.S. Preventative Service Task Force recommends that all women 65 years of age and older and younger women with significant risk factors be screened for it. So we're able to screen that. It then talks about there's insufficient data to say that men should be scanned as often as women, but make sure that you go ahead and read through all of that on page 277. You then have your risk factors for osteoporosis in the box 21.1. It talks about the non-modifiable, so your gender, if you're a female, your race, your age, and your family history. And then it has your modifiable risk factors, which is your weight, if the patient is underweight. So here we have a disorder, osteoporosis, that is more common in those that are lower weight than are higher weight. The diet, hormonal deficiencies, activity levels, medications, and cigarette smoking. So we have those different medications that can actually break down bones, leading to osteopenia and then potentially osteoporosis. So that picture right there is just a picture that comes from figure 21.1 on page 277, and you can read and look through that. And then there's the risk factors that we just went through. And then it goes into reducing the related risk and injury of osteoporosis. And your book, and I actually outlined this myself, was weight-bearing physical activity such as brisk walking, carrying light weights, helps to maintain bone mass by applying mechanical forces, spine and long bones. Muscle building exercise help to maintain skeletal architecture by improving muscle strength and flexibility. And then so the things that, again, that we can do, the first one there listed, increase weight bearing and muscle building exercises, improve on diet, don't smoke, follow fall precautions, prevent injuries in the home by making sure the homes are safe, and appropriate ways to take and manage medications. Then talks about pharmacological interventions, which they go into a great deal of calcium and vitamin D. It talks about with the calcium that it gives you the numbers. I am not going to need you to know the numbers, but just make sure that you read through that and know that osteoporosis can be helped with things like calcium and vitamin D supplements. It actually talks in there about how the calcium carbonate with vitamin D is recommended because remember, we need that D in order to take in the calcium. Good nursing care includes working with the person to develop effective bowel regimens because calcium, the biggest reason patients don't want to take their calcium is because it causes constipation. And as we know with older patients, that constipation is already an issue because of, not drinking enough medications and things of that nature. Also talks about older adults being at high risk for vitamin D deficiencies, and those are especially us in the climates that we live in, because of skin changes that reduce the ability to synthesize vitamin D. Here we keep ourselves covered a lot because it's cold outside and we don't get to see the sun all that often in the winter months. So make sure that you read through that. Sources of calcium is listed here, so important for us to be able to teach our patients where we can get sources of calcium besides in supplements. Foods are a better way than supplements, but so that gives you a nice list right there. It's also on page 278, box 21-2. And then we're going to move into arthritis. Let me see if there's anything left that I highlighted in here. Oh, they do talk about the medications that can be given to patients that are developed. It says all increased bone mass, reduced bone turnover, or both. They are available in oral and injectable forms. And then so you'll see that's listed on it's on page 279. But they're very expensive and are typically given in unique circumstances. So we do have those medications. Whoops, I moved past that. So arthritis is a term used to apply to more than 100 musculoskeletal conditions. So the word arthritis in itself is all-encompassing for many, many disorders that we have, and we're going to cover some of these, the ones that are listed there below you. You'll see these are more common in women and increased risk after age of 55. So osteoarthritis, on page 279, this is the most common form of arthritis. It's a degenerative joint disorder. Risk factors include genetic predispositions, so the family, local inflammation, joint integrity, mechanical forces, and cellular and biochemical processes. After the age of 65, women and men are affected and will have radiographic evidence of OA even if they are asymptomatic. So a lot of people are going to be affected with osteoarthritis. If you look over on page 280, you actually can see a normal joint versus a diseased joint. I wonder if that might be coming up actually. Let's see. Nope, it's not. So anyway, let me just talk about it. So look at on page 280. You'll see like the synovial fluid, the cartilage, the bone, and all of that in the comparison to the diseased joint where the cartilage is all worn and broken down. There's not the smoothness of synovial fluid like there is. The bones are more hard, and so underneath this picture it talks about in classic OA there's stiffness with an activity that may be relieved by activity, and it's funny because at the same time the activity may lead to pain and rest is going to relieve it. So unfortunately for these patients that's something difficult to deal with because resting can help, but it can be inflamed during resting. Crepitus, that is a crunching or popping sound, may be detected during the exam. The most common location for OA is the knee, followed by hands, hip, and feet. So the more that cartilage wears down and thins out that synovial fluid, and then the bones end up rubbing on each other, and that obviously causes inflammation and significant pain. Joint replacement procedures, this is an arthroplasty, may be done for OA in the knee, shoulder, or hip. And then the book even goes on to talk about some patients of upper age can have these or joint replacements, even though they're upper age, that it can be helpful to eliminate or help with the pain. Oh, here's the picture, of course, after I talked all about it. So again, there's the differences between those. And then the areas that osteoarthritis affects, that picture is also on page 280. Those are the common locations, so your lumbar, the back, the hips, the knees, the fingers. Polymyalgia rheumatica. This is a common inflammatory disease which the cause is unknown. This is on page 280 as well. It's one of the more common inflammatory diseases, especially in Caucasian women. Again, a lot of times, though, it does occur with the one that we're going to talk about next, giant cell arteritis. Both their causes are unknown, but they are associated with immune disorders and genetic factors. It talks about how polymyalgia rheumatica can develop suddenly as overnight, or it can develop slowly. It lists the different symptoms that the patient will have, but the pain is usually greatest at night and in the early morning, but typically without the joint inflammation that we're going to see with osteoarthritis. It is rare in people younger than 50 and becomes more common as age increases. And then giant cell arteritis is also known as temporal arteritis. I am saying that right? Yeah, I am. Okay. Anyway, it may occur at the same time as the PMR, which we just talked about. It's primarily an acute inflammation of the arteries of the scalp in the temporal area, but medium to large vessels may be involved as well. The inflammation causes restricted blood flow and may cause very serious and permanent damage such as stroke or blindness. So with these patients, if we're screening them for this and they've got, especially if they've got polymyalgia rheumatica, and we know we're looking for giant cell arteritis as well, we want to be sure that we're doing all of our assessment with them. Obviously, dizziness, problems with coordination, and sudden changes in vision could be all things that we would see in a patient with giant cell arteritis. So the treatment is high-dose steroids. So rheumatoid arthritis is our next one. We hear a lot about this. RA, we see a lot of commercials on TV for medications for this. Is a chronic systemic inflammatory joint disorder. It's considered autoimmune, and you can read the rest of that in your book. It says the cause is unknown. It affects 1.5 million people. RA is characterized by pain and swelling in symmetrical joints, for example, either both hands, both sides of the hip. It generally affects the small joints of the wrist, the ankle, or the hand, although it can affect large joints as well. Whereas morning stiffness in OA lasts less than 30 minutes, RA lasts longer than 30 minutes. And it's systemic, as we just said. The joints are warm and tender. Weight loss is common. The natural course of RA is highly variable with good and bad days. So patients will have days that are not nearly as bad and other days that are pretty bad for them. It used to be that we would treat with NSAIDs and we would save bigger drugs for later, but now they're actually saying that we want to try to halt this damage earlier on. So you'll see there's disease-modifying anti-rheumatic drugs. So they're called DMARDs, all right? All DMARDs are potentially toxic and administered with care by a registered nurse. And so make sure you just kind of go over what a DMARD is. I actually Googled them to look them up, and just so you have an idea. Okay, you don't have to know them in depth, just have an idea of what they're used for. As with osteoarthritis, the care for rheumatoid arthritis is palliative, so we want to make sure we make them comfort and try to delay the progress of disease as long as possible. So side effects of the DMARDs are listed here for you. And then gout. Gout is an inflammatory arthritis that happens in older adults. It appears to be from the result of accumulation of uric acid crystals in a joint. Uric acid is produced when purines found in food break down. So we know that the most common location is the great toe for patients. It's the proximal joint of the great toe is the most typical site, although sometimes the ankle, knee, wrist, and elbow can be involved. We know that we want the patient to stop drinking alcohol and to eat foods that, avoid foods that are high in purines. And box 21.4 lists the foods that are high in purines. So make sure that you go over that and understand that, because if it's important for us to know which meal would be important or would be available, or a better meal for a patient with gout. And then the rest of this just outlines the implications. Page 283, it starts on page 282, interventions. I have a lot of stuff highlighted under there, so it's important for you to read that whole page of 283. You'll notice that on figure 21.4, it's got the Heberden nodes and the Bouchard nodes that we may see on a patient with hand deformities and arthritis. Make sure you take a look at those. Actually, there they are right there for you. So you can see the difference between the Heberden and the Bouchard. And then our goals for our patient and interventions that we're going to do. Make sure you read through that. That also talks about complementary and alternative interventions. I didn't highlight anything in that. Majority of my highlighting happened on page 283 when it comes to the things that nurses can do to help our patients with these different forms of arthritis. Be sure if you have any questions to put those into the discussion board, and hopefully this will all we'll be able to review all this on Monday and Wednesday when we come together.